So I think we can start. Rima did the proposal of having this new type of activities, which is the Cath Lab Nightmares, and I appreciated it. It's a great idea. So the idea is that each fellow of the DCB Academy will present one complication that he or she had previously in his career, or also a complication that he or she didn't have, but somebody else had, and we'll comment on that. And we will interrupt, hopefully many times, in order to understand and to say what we would have done. So this should be a very interactive activity. So this is an experiment, the first time we do this, but I'm happy, I'm excited to see what Rima has brought us. So Rima, please.
Thank you.
Share your screen.
Okay. So good morning, everyone. It's with great pleasure that I extend a warm welcome to each and every one of you joining us today. My name is Rima, and I have the privilege of serving as your host for today's session. Before we delve into our presentation, I would like to welcome our esteemed moderator, Professor Cortez, and thank him for these activities. Once again, welcome everyone. Thank you for being part of our new project. Let's make today's session both informative and enjoyable for all. So this is our logo. We started this activity starting from today and timely monthly. I will start directly with my case presentation. This is a 58-year-old female with a past medical history of diabetes, dyslipidemia, and COPD, presented with the chest pain and positive ischemic test. Her cath lab, showed, as you can see here.
This is a miniaturized angel, but
I have another photos.
All right.
Okay, so her cath showed a significant relief, as you can see here.
Yeah.
And they decided to do left main stenting. So we started.
Can I see the previous one just to see? Sure. Yeah, the disease extending to the left main. Okay. Okay. So with this, you didn't do any imaging.
They do imaging, no, but they do. They did as test for vasospasm, nitroglycerin, and the lesion stayed there, and they do ischemic test. I think they do. They did MRI ischemic test.
Yeah, yeah, but this, you know, we have seen, we have participated to a lesson about INOCA, so we can have also positive stress test without significant lesions. So I'm not saying this is not significant, but this is just one single shot. And I would do imaging to be sure that this is a significant lesion with a reduced area. Yes, so this is mandatory. And also, if you decide to do left main PCI, we have seen also from our study, but also from other studies, that you must do imaging, also up front, not only in the end. Okay, okay, please, go ahead.
So they decided to do left main stenting. The problem here, they tried to do the radial approach, but it was very, very painful to the patient, and they did radial spasm. So they prefer the femoral approach. So they started with the right femoral approach. And here we inserted
the other thing, I understand this, but the other thing is that how was the length of the stent selected? Because
4 times 8 millimeter.
Huh? Excuse
4
me?
times 8.
Yeah, but how was this length decided, and also the diameter? you just have 1 or 2 shots by angio,
Yeah.
and usually from the anatomical from the anatomy, we know that the extension of left main disease is usually also occurring in 80% of the cases to the proximal LAD or to the circ. So this seems to me a quite short stenting just for the left main. Okay, let's go ahead.
So here in this case, I was not present in this.
Yeah, but you don't have to justify. This is nightmare. So probably some complication will arise, and I wanted just to comment up front. I've not seen the case, I have to admit.
So they decided to do left main stenting. We started with an EBU 3.5, 2 wires in the LAD and in circumflex artery. And here they started to do some injections to adjust the position of the stent. But unfortunately, in this second shot, the fellow started to do inflation of the balloon without confirming, without the confirmation of the operator.
Okay.
He was not such experienced fellow, and he started to inflate the balloon even without fluoroscopy. So before doing fluoroscopy, before adjusting the stent.
Okay.
So as we can see here, he started to inflate the balloon.
But let me understand, the fellow was the primary operator of this case?
No, he inflated the balloon.
Okay, just inflate the balloon, all right.
Yeah.
Okay.
So here.
Another important thing before you go ahead, I would like to understand from the fellows, our fellows, which is, in your opinion, the best view to inflate a stent that you want it to cover completely the left main? I wanted just to understand which is your habit, which is your common, normal, preferred view for
to me, the spider view.
Elevocranial for left main ostium.
I tend to use elevocranial. I do check in an orthogonal view as well, so either an LAO or a spider view. But I tend to deploy in the elevocranial. If I'm trying to nail the ostium, I also put a sepal wire to mark my ostium, and I can pull my stent back to the sepal wire. It's kind of like just a wire in the aorta. The guide
in the sinus.
Yeah. So I know exactly where my aortic sinus is, and then I can pull the stent and know where the marker sits. It lines up with the wire. So I find that quite useful. But elevocranial is what I tend to use.
All right. Yeah, what is important is just to check it, mostly if you use a short stent, like in this case. With short stents in the left main, it is easier to lose the lesion, to have 2 orthogonal views. This is very, very important. You can use the elevocranial and the spider, or the retrocranial and the spider, that according to your experience, no problem. And then I would like to understand if you have never seen or practiced the Szabo technique. Does anybody know what is it?
To insert a wire in the aorta and wire in the LAD to locate exactly the ostial part.
Yeah,
I think it's actually. Yeah, sorry. Go ahead.
No, go ahead. Sorry.
Actually, I think
Actually,
it's threading a wire through the proximal stent strut to try and then railing the stent over your normal wire. But I think one of the problems with that is there's been a lot of instances of lost stent, or LSD or stent deformation as a result. So I mean, I personally have not done it. I use some other strategies like live IVUS to try and nail the ostium or a sepal wire. Yeah,
correct. Rima, you take the stent, you just you take the stent before inflation, you take it in your hands, you just take the first strut, and then you let a new wire, a second wire, cross the strut in order to keep it in the ostium. I personally, like Bharat, I personally don't like that technique. I don't use. I've used it a couple of times, but in my opinion, it is complex. You have the risk, as Bharat said, to lose the stent, especially in short stents, and it does not add anything. So just as a cultural point, I wanted to let you know that previously, 20 years ago, even more, they proposed this. So please go ahead, Rima.
Professor, I just want to interfere at this stage. Sorry, just
Yes,
have one
please,
more thing I
you have
want to
to.
discuss. Conventionally, we are doing, especially when you are covering the left main ostium, we came into the iliocranial view to look for the roof of the left main, especially when we are not having us imaging catheters with us. Then I discussed this thing with one of the live lectures with Professor Ilyas Hanna. He said that I am not covering the roof of the left main, I am covering the lower border of the left main, because lower border is more in line with the aorta rather than the roof of the left main. So what is your opinion about this? Any idea? I want to just confirm.
That makes sense, but still I prefer to see the left main in a striped way. So my two preferred views for this type of lesions are the RAO cranial and the AP caudal. I don't use the spider actually.
Oh,
so in this way, I can see the left main straight in these two orthogonal projections.
Thank you.
Okay, let's go ahead, Rima, please.
Okay. So here the operator started to just check where the stent is. He cannot see directly the injection, but the patient started to do some agitation, and she moved her leg. The system goes out.
Wow.
The wires and the guided catheter. So he tried to do re-intubation here to just check on the stent. And this is the result. I will show you here. What's going on?
You tell us.
Can you see the
it's in the distal part of the guiding catheter or what?
No, we cannot see the stent even.
Yeah.
There is no stent.
Yeah, but the distal part of the guiding catheter seems smaller than the more proximal part. What is it?
I guess from the view, no?
It's just a view. Okay.
Yeah.
Yeah. Okay.
So here the operator conclude that the stent is lost, and he do traveling of the
body
of the table to see where the stent is, and here it is in the pelvic area in the left part. So
all right.
You forget about this, and what do you do in this situation?
Okay, so it's a question for us. So, Vakas, what would you do now? This patient, you have a stent lost somewhere in the pelvic area, but you need to understand where it is just to see if it can create problems. But you still have this lesion, which, in my opinion, is not well characterized in the left main. So, what would you do?
At this moment,
I have a similar situation once happened during my interventional cardiology training. To me, what I have learned from the different workshops and mostly the peripheral stents, they said that they are not very much problematic because peripheral vessels are mostly large vessels, and if it will not cause some problem, especially if the stent went into some small vessel. So most of the situation, if the peripheral showering of the stent, just leave it. Or if it is easily accessible, you can access from the peripheral side and get it out. If not accessible, then nothing, to just keep the patient on the conservative and look into it. This is two different approaches. If it is easily accessible, you can approach from the peripheral side, you can get into it. But if it is not accessible and difficult, and you can see that you can even more harm the patient, then peripheral stenting. If no clinical sequence occur, then just leave it. This is what I have learned.
Okay. And what about original disease?
Original disease, for especially what you want to about left main stem disease in this case?
Yeah, what would you do now? Okay, you approach that, you lose the stent,
yes.
And then what would you do?
If the stent lies within the wire, within the catheter, then there are a lot of techniques to get this stent out of the catheter.
No. Okay, we forget about the stent. So what would you do in this patient?
To me, this is definitely the case of right from the beginning. This is the case which we can do with the imaging catheter like IVUS. IVUS must be very important because first of all, this left main disease is questionable disease to me, and and there's definitely imaging will help. But without imaging, you are approaching the left main even without having the Cath Lab Cath team meeting. I think this is something need to be worked up.
Okay, so your point is the indication and the approach to this left main disease was a little bit doubtful without imaging, and also the choice of the stent was probably in terms of length, maybe not the correct one. So I would do imaging. Okay, thank you. Would anybody else do something different?
But how is doing the patient at this moment? Is it
Excuse
fine?
me, Alessandra.
Yes, she's fine.
Okay, so she was
Stable
asymptomatic. Yeah. Okay. So would anybody stop the procedure and reschedule it, or since it was still at the beginning, you would go on, or would you have a different approach? You would send a patient to surgery. Which is your approach?
Was there any ballooning preparation done, or was it just an attempt to direct stent?
Direct stenting, because they did
direct stenting
before procedure, and there is no calcification in the left main, so they decided to do direct stenting of the left main.
Yeah, one of the problems with direct stenting in ostia is that sometimes it can be quite fibrotic, and that can cause slip. The stent or the balloon to slip as well. So I always tend to pre-dilate, get a feel of it, and obviously imaging to kind of guide whether you need any preparatory work. Sometimes I tend to use scoring or cutting balloons for osteal lesions because I find it just grips a bit better and it prepares the lesion, allowing you to then deploy your devices without too much movement or slippage. Especially with the short 408, the chance of slipping, even if you had got it on the right spot, is actually quite high. So I guess you haven't ballooned anything, but maybe you need to try looking for the stent and then think about finishing the procedure if you're quite convinced that it's a significant osteal left main lesion.
Yeah. Also because at this stage, a balloon with a stent was inflated, probably at least in the proximal part of the left main. So you probably would have caused some disease at the left main. So I agree that I would go on with the procedure, and of course, imaging that should have been used before must be done at this stage. So this is my point.
Sorry.
Okay.
May I ask you,
Alessandra? Please.
No, just may I ask you how the patient is doing now? He is fine?
She's fine. She's stable, yeah.
Okay.
I agree with you all with the imaging technique. IVUS before it's a very questionable lesion in the left main, but because the IVUS in our center is not working, so they proceed with the scan and the ischemic.
It's not working because it's broken and it's in maintenance or what? Yeah. So no, I'm a little bit strict about that. So this is a lesion setting with a patient without atherosclerotic disease, unless doubtful atherosclerotic disease in the left main. But doing a PCI in the left main is associated with a high degree of events, also a simple lesion. So in my opinion, if you don't have imaging, you don't have to do this type of procedures. So you reschedule when you have the IVUS. So the fact that you don't have imaging is not a justification for doing this type of procedures in a cath lab. For that, I'm completely strict.
Okay. Thank you.
Okay, please, Rima, go ahead.
So the operator here, for me, just take a deep breath, relax, think priorities, and don't forget left main first. So he decided to do left main stenting, which is now successfully done. I think here the problem in the first case, in the first inflation, he didn't do the correct inflation of the balloon. So he did for 12 or 14 only. So the stent was not well deployed in the left main. That's why we are losing the stent in the first inflation.
Yes, but also for maybe because the stent was undersized. It was a 3.5, if I remember well, the first one.
4 times 8, the same stent he used.
It was 4.8. Okay,
4.8.
I understood. Okay. Yeah.
And this is
And so in this case, the stent was deployed from the ostium to the distal part without involving LAD or circ. Okay.
Yeah.
Right.
And this is the final result.
Yeah. Perfect.
Okay. And now it's time to fix the problem that he did. So he started to, we already punctured the right femoral artery. So we passed the pigtail here and we did the images. And as you can see here, the stent is mainly in the left internal iliac artery.
Yeah.
And the kind reminder of the aortic branches. So this is the abdominal aorta. This is the bifurcation, the left common iliac artery, which is divided into left internal iliac artery and the left external iliac artery. Left internal iliac artery, here our stent is lost, or left hypogastric artery. So as you can see here in the images, there is our stent, expanded stent dislodgement. So what's your solution? I guess Wagas give us the two technique. You can either do snaring technique to the contralateral part or crush.
Sylvia, are you commenting on this or what?
Excuse me.
I'm sorry for the noise.
Okay, so you didn't want to comment. Okay, so any comment on this? What would you do? Would you leave the stent there, or would you do something else?
Trying to, this is the internal iliac artery. To me, I tell about my experience. While doing our EVAR procedures, especially when we are taking the next long length of EVAR, continuation of EVAR, most of the time we are obstructing the one side of the internal iliac artery. We used to plug it because internal iliac arteries, these two arteries from both sides, they are having a high collateral supplies to each other. If one internal iliac artery goes closed, the other supply it very much. So this is to avoid the leak in case of EVAR. This is what we have learned. Now, in this case, you have done right thing. There are certain options. Once you are inside the internal iliac artery, try to snare it. But I think snare catheter size and this is the issue to you. I think next there are certain other techniques like you put multiple wires and try to overlap these wires more so that it can entangle your stent and get it out. This is also one of the way. Other thing
multiple
is that,
wires.
Yeah, multiple wires and try to rotate them like anti-clock,
Yeah,
clock,
but
anti-clock. Try to entangle the stent. Yeah.
You would do in this way a curettage to the artery. You would completely destroy the endothelium of the artery. So this is something really violent.
This is issue.
I would avoid that. Okay, thanks, Wakas. Any other comment on that?
Yeah. Am I audible? Hello?
We can't hear very well. Who is speaking?
Yeah. So I'm Dr. Kripal.
Okay.
Yeah. There are two possibilities we can do for the migrated stent. One is actually we can snare it. It's very easy. Or we can actually, because it's an inflated stent, we can pass a balloon, new balloon, over the wire and then inflate distal to the stent.
Yeah. This is a possible technique, Krupal. The only thing is that you have to be sure that it is aligned with the artery. So if it's aligned, you can cross it with the wire, inflate the balloon, and pull it back. But then when you have it in the common iliac artery, then you may still have some problems because it's an inflated stent, a 4-0 stent that would never enter inside of a 6 French or 7 French guiding catheter. So there you have to snare it anyhow. So it's not
snare
so.
Is the easiest. Snaring is easiest because it will just trim the stent and the stent itself can come into the sheath also because it gets trimmed and kind of twisted, like it will easily come. It's very soft, like we can easily crimp it with the snare loop.
Yeah, you can do that, but the only thing is that the stent should be aligned with the flow and with the vessel. Because if it's not, if it's put in a cross, for example, in a crossway, it would be difficult to without creating damage to the artery to pull it.
Yes,
okay, so Rima, let's go ahead.
So the operator here decided to do stent crush. So he used a balloon 5 times 20 millimeter. He inserted the wire, and he started to crush the stent on the contralateral wall of the iliac artery, as you can see here.
Okay.
And this is the final result.
All right.
Okay. So this is our materials, and just for final issue, they used the proglide per close technique, the vascular closure technique, to close the femoral puncture.
But you used a 6 French or what?
6 French.
So you use a proglide for closing that. Oh, okay.
I didn't finish the case, so just take home message from this our first part. Expanded stent dislodgement is infrequently encountered. Optimal stent sizing and balloon expansion is crucial to reduce the likelihood of dislodgement, especially in large diameter vessels. Monitoring stent position during inflation and withdrawal of stent balloon is key to early recognition of stent dislodgement. Employing prompt and safe retrieval techniques is helpful to avoid stent loss and stent embolization. Trapping an expanded stent with a balloon and contralateral femoral access to snare and entrapped stent are safe transcatheter options to successfully retrieve and dislodge an entrapped stent without need for a more invasive surgical approach. And for sure, employing the expertise of a vascular surgeon is advisable to avoid vascular complication. So, and the important issue to stay calm and think how to approach in each complication.
Yeah.
Same patient after 2 weeks presented with a right lower pain, limb pain, with absent right dorsalis pedis artery pulse, with a Doppler echo that showed subocclusive right external iliac artery.
Wow.
What's happening here?
So it's a question?
Yeah. What do you think?
I think you should check.
Okay. So unfortunately, the patient did right femoral artery occlusion after the ProGlide vascular device closure.
Oh.
And this is her.
From ProGlide,
The
it is very
stenosis was here, and all of this traject are filled with thrombus material.
actually before inserting the ProGlide, we are using the injection to look for the disease. If there's disease, then do not put the ProGlide. If there is disease free, then you can, especially the anterior wall of the artery, you need to check that this puncture is from the anterior wall of the artery rather than the lateral or something.
They do this systematically after every injection of the femoral artery or puncture of the femoral artery. They did an images for baseline images. So the iliac artery was normal in the first case.
Can I just ask, is it normal to do femoral PCI in your center, or do you also do a lot of radial? Because was there any contraindication for radial here?
They used the radial approach in the first case, but the problem was she did the severe spasm of the radial artery, so they shifted the
okay.
Here they used the radial artery.
Thank you.
What we apply, and it's very important here, is any right femoral or left femoral puncture is done under echo guidance.
Yeah.
So are you implementing these in your Cath Lab?
Yes.
Okay, so in this case, the femoral artery was punctured with an echo guidance.
Yes. Okay. The problem here is the ProGlide closure technique.
Yeah. Yeah, but you have to understand why you had this problem. Sometimes it goes capturing some, some calcium or what. So if you have an echo, you can at least predict some of the possible complications.
I guess the technique they used, I will show you.
Yeah.
Here they decided to do angioplasty of the right femoral artery. And this is the result with the post remaining thrombus here. They left it on anticoagulation.
And which were the antiplatelets used for this patient?
Clopidogrel and aspirin.
Okay.
So this is one of the mechanism of the closure technique. This is a ProGlide technique. They use the sutures side to close the femoral axis. So the figure A shows the feet length and the proper deployment of the ProGlide, which is positioned with both the anterior and posterior feet against the anterior wall of common femoral artery. In the next figure, we can see here one of the mechanisms how we can do a problem with the ProGlide occlusion of the vessel or so on. So here, figure B shows an illustration of the occlusion mechanism. Because the puncture angle is less than 45 degrees, the anterior foot stitches to the anterior arterial wall twice, and the posterior feet dissected the posterior arterial wall. This is one of the mechanism of the theory of the occlusion occluded artery after ProGlide technique.
Okay. So you mean that in this case, in your opinion, the ProGlide wasn't pulled sufficiently to keep the anchor to close the vessel hole? All right. Yeah, could be.
Okay. So a few words about the per-close ProGlide. The suture-mediated closure device system is indicated for percutaneous access close to the common femoral artery and vein in patients who undergo cath. ProGlide has two pairs of non-absorbable polyester sutures and is indicated for 5 to 21 French femoral arteriotomy sites. It's important to check the presence of claudication and the dorsal pedis artery pulse after using ProGlide systematically. The treatment of stenosis or occlusion with the use of ProGlide is reported to be surgical angioplasty and catheter treatment with balloon angioplasty or stent implantation, as our case. Catheter treatment may be the first choice. However, balloon angioplasty is associated with a risk of residual stenosis and dissection. Moreover, stent implantation at common femoral artery, which is the so-called non-stenting zone, carries a high risk of stent fracture because of the constant flexion of the inguinal ligament. When catheter treatment is uncertain, surgical repair should be performed. And since occlusion by the proglide occurs through various mechanisms, it's important to perform surgical treatment even after catheter treatment. And the treatment of the common femoral artery occlusion using vascular closure device, such as the proglide, may be better with surgical repair than with catheter treatment. And this is one of the how do you treat surgically? So the torn artery here was cut out and underwent end-to-end anastomosis.
Yeah.
Thank you.
All right. Thank you, Rima. We already had a lot of discussions,
Yeah.
but I would like to understand if there are points that some of you would like to raise on top of what we have said so far. Any other comment?
What we conclude is imaging is very important during these high-risk cases, especially when you're doing the left mainstem disease. And apart from the selection of the patient, imaging is mandatory, especially IVUS or IVUS in this case.
Yeah.
Mm-hmm.
Yeah, this is the key message. Yes, I think it's very important to say that. Also because a 4/0/8 stent was employed. At which atmosphere? At how many atmospheres was it employed?
In the second part,
Yeah.
20 atmosphere.
20 atmospheres,
Yeah.
so it would reach 4.5 maybe.
Yeah.
And
Yeah.
did you use any post-dilatation?
No, they didn't use.
No post-dilatation. So I don't know if you size the artery according to the CT scan, but no, something completely off-label. So the other point is to use imaging also after stenting in these important, prognostically important places. So in order to see if it's completely opposed to the vessel wall, this is paramount importance. I think that expansion here would not be a problem because calcification is not visible, at least angiographically, but their position is of paramount importance in my opinion.
Just out of curiosity, what stent was it? What stent platform?
Synergy.
Synergy. Okay, yeah. And was it the Megatron or was it just the normal Synergy XD?
Normal one.
The normal one. Okay.
Yeah.
Thank you. Just the visibility is quite different for both of those.
Yeah.
Because of the strut thickness. So I tend to use for left main, I tend to use something a bit more visible. And also if you lose it, it's easier to find it. So it's good that you managed to find it in the iliac artery.
Yeah. Okay, Rima, thank you for this. If there are no more points or questions, I think we started this new activity in the perfect way. There were a lot of comments. It's a didactical case, what we should do, what we shouldn't do.
Yeah.
And I hope that any of us has taken something which will be useful for our next patients, for sure.
Yeah.
Okay, so